right, let's go. All right, hello, thank you for being here. My name's Ashley Wagoner, and my co-presenters are Tom Sehan and Haley Anderson. Today, we're presenting our research project entitled Transcutaneous Electrical Stimulation in Spinal Cord Injury, a narrative review. To begin, I'd like to show you this video courtesy of Craig Hospital. This gentleman is in his early 20s with a diagnosis of AIS-B spinal cord injury, or SCI, at the C6 level. This diagnosis indicates he has no motor function preserved below the level of his injury, and it is highly unlikely to return. But here he is, volitionally moving his left leg for the first time in 2.5 years. Recent innovations in neuromodulation have the potential to change what is possible for people with motor complete spinal cord injury, and that's what we're here to discuss today. This man is undergoing his first session of transcutaneous spinal cord stimulation, abbreviated TSCS, in which electrical stimulation electrodes are placed on the skin over specific segments of the spinal cord with the goal of inducing a desired motor response. In 1982, Marsden and colleagues were the first to show that TSCS was able to excite spinal cord neural structures in uninjured people. Early in the past decade, researchers used this non-invasive spinal cord stimulation to activate spinal cord central pattern generators for walking in uninjured participants, as well as to reduce spasticity in people with SCI. So TSCS showed potential to not only reduce spasticity, but possibly improve motor output in people with SCI. It has not yet, however, been able to restore overground walking as surgically implanted stimulation has. Implanted stimulation is expensive, invasive, and carries the same risks as any surgery, so it is important to determine whether similar effects can be elicited using TSCS. Within the past 10 years, research evaluating the impact of TSCS on voluntary motor control after SCI has rapidly expanded. The purpose of this narrative review is to summarize the current state of TSCS research as it applies to volitional control of motor output and bladder function following SCI, and to provide clarity on the theorized mechanisms behind its efficacy. So our literature search was performed from January to March 2020 in the EBSCO host databases Academic Search Premier, CINAHL, Medline, and PubMed. The search terms spinal cord injury, motor function, and transcutaneous spinal cord stimulation produced 90 results. After removal of any duplicates and results not peer-reviewed, we were left with 37 results. We then eliminated any articles not related to motor function or potential mechanisms behind TSCS in people with SCI, and we were left with the 13 articles further reviewed here.
Thank you, Ashley. Before discussing the implication of TSCS on motor output, it's important to understand the severity of injury patients have endured that are seeing benefit from this new intervention. So TSCS has been shown to improve function in those with AIS-A and AIS-B spinal cord injuries. These individuals at best have an incomplete spinal cord injury where there's no motor function below the injury while sensory function is intact, and at worst no longer have either. This means that TSCS has been shown to benefit individuals with long-term motor complete injuries, such as the patient seen in the video. Transcutaneous spinal cord stimulation is a scientific breakthrough by nature because it is a much less invasive option to restore function in motor complete spinal cord injuries. It has been shown to restore standing capacity and step pattern generation. In a 2015 study, subjects with motor complete SCI regained voluntary step-like motions after a 4-week period of passive step training coupled with TSCS to the lower thoracic and coccygeal spinal regions. While another study of 15 patients in SCI, all subjects regained the ability to stand upright with the use of their upper extremities for balance and minimal to no assistance when TSCS was applied. In addition to this, it has been shown to improve upper extremity function. Another study quantified the carryover, reporting a 325% increase in grip strength with stimulation that persisted at 225% when stimulation was removed. Further research has shown improvements in trunk stabilization as well as urethral and urinary voiding capacity. Motor control has been shown to be improved after the intervention is removed, and all of these have resounding implications on quality of life. So as far as the mechanisms, transcutaneous electrical spinal cord stimulation is still in its infancy. This means that mechanisms are largely unknown, requiring further study. This is similar to the outpatient modality of dry needling, in which the exact physiologic change is debated, but the improvements are notable. However, the applications of TSCS stimulation may provide much more significant impacts on the functional capacity of patient and their ability to recover and prevent any secondary sequelae that might develop. So if you will direct your attention to the figures at the top right of the poster, neurons are fragile. This means that cells do not need to be completely obliterated to lose electrical viability. Seeing how most spinal trauma does not remove the remaining spinal cord below the injury site, it is possible that there are neurons that remain but are no longer functional. The prevailing theory thus far is that the research is TSCS turns up the volume in a sense. As the signals travel via large afferent fibers, the energy is spread out throughout the dorsal horn to lead to efferent signals. It is debated whether these signals travel along the propriospinal network or neural relays that have yet to be distinguished. Because the mechanisms are not well known, researchers are still investigating the best placement of the modality to lead to the best outcomes. Simply put, it is theorized that TSCS raises the overall resting membrane potential of the spinal networks in question so that volitional signals are able to make up the difference, leading to motor output. Through repeated task-specific training, it is thought that repeated simulation reinforces these pathways and may lead to neuroplastic changes, explaining the carryover effect in which there was improved motor function after the intervention was removed.
Thanks, Tom. So overall, our big takeaway here is that repetitive task-specific training in combination with TSCS has shown the ability to restore some neural connections. TSCS showed improvements in voluntary motor function previously thought impossible with these sort of patients. Some future directions as well as limitations here. So in our present research, there lacked a standardized set of stimulation parameters, so that would be good to research further. And although since our search there's also been more published, we still need more research into the lower urinary function to generalize from animal studies to more of human potential. There's also been no FDA approval yet for TSCS, so we need more large clinical trials for feasibility and safety considerations. And we also need more research to directly compare TSCS to ESCS. Now, in terms of clinical relevance, overall, this really shows a shift in physical therapy care from compensation more to recovery-based interventions. And a couple of exciting potential uses in non-medical settings for TSCS are that units could one day allow patients to themselves exercise and really just combat issues such as cardiovascular disease and diabetes that patients with SCI often have issues with due to their impairments. So we may in the future see this use at home or even in places like adaptive gyms. You may imagine gyms having these units for their members to allow them to do things like personal training, group classes, and even recreational sports, and really just help them to find a community of people going through similar experiences as well. And also in terms of feasibility for a clinic to have this sort of therapy is that TSCS is cheaper, it's easier to apply, and is less invasive than ESCS. It's analogous to a normal stimulation unit, especially as they are developed further in the future. And in relation to the other research done in our larger neuro group, basically, if we can combine predictive information, such as the previous group talked about, with potentially therapeutic interventions, we can really be more successful from the beginning at injury onset through potential recovery. And like I said, just hoping for a shift, at least in the research and in thinking toward more and more to recovery-based interventions. So if we looked at our references here, some of our core references here include information on mechanisms, urinary function, as well as a large recent systematic review. And you can also see the QR code on the screen for more references at the conclusion of our published paper. And really to bring it all together, we want to throw some acknowledgements out there. So we really want to thank Dr. Andrew Smith, who is not only our faculty advisor and offered so much valuable guidance during this, but was also a huge collaborator and teacher overall. We also want to thank Dr. Megan Roswood, Dr. Rachel Tappan, and Dr. Candy Tiefertiller for their contributions as well. And we also acknowledge all these institutions below for their contributions and thank them as well. So we'd like to open it up for any questions that you have, and thank you so much.